Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you are able to join us virtually today for our next webinar. The Trust is pleased to once again partner with Drs. Sarah Smucker Barnwell and Margot Adams Larson to present these telehealth community chats. They have done a tremendous job with this series, and I know I and our policyholders appreciate their expertise and the time and effort that goes into putting these together. I'd also like to take a second to remind you that the CE earned from our chats can be used to fulfill SIPAC's 3-hour CE requirement for their e-passport renewal. If you're unfamiliar with SIPAC, which stands for the Psychology Interjurisdictional Compact, I encourage you to visit their website at www.sipac.org for more information. I know you're going to enjoy and benefit from our telehealth chat today, so let me not tarry anymore. Please join me in welcoming Dr. Smucker Barnwell and Adams Larson.
Thank you so much, Dr. Martin. Thank you also to Dr. Chisholm, to the Trust, and all the amazing staff. And thanks everyone who is joining us today. We really appreciate it. Margot, it's great to see you, Chat 19. I can't believe it.
I know, it's great to see you too, Sarah. I am so excited with all the things we're bringing today. These are our quarterly check-ins. It's our discussion of practical how-to information from an ethical perspective. And we like to emphasize that now, that this is there to help you meet some of those ethics CEs as well. And we do take the questions in advance. You can write them in today's evaluation. We go through those and pull the questions out that we've left unanswered. But you can also drop them live in the Q&A today, and we will be getting to some of those as we go through our time together. If you'd like to email us, you can email at telehealthcommunity@trustinsurance.com, and we will pick up your questions there as well. So as usual, we don't have slides for this because it's conversational and back and forth, and we've just got so many amazing things to get into and dig into. There's been a lot going on.
Busy quarter.
It has been. I don't know where it went. So without further ado, I'm just going to update a couple really quick things. The SIPAC, as Dr. Martin mentioned earlier, it has now been enacted in 36 different jurisdictions. It's effective in 34, and there's been legislation introduced in 6 more in 2023. So this is going to be a busy year for some mobility issues for us as psychologists. Also, for those who are in a military spousal position, there was a law enacted, federal legislation that was signed into law in the beginning of January that will now allow more ease for military spouses as they are moving with their spouses on deployment, so they can transfer more easily into non-licensed jurisdictions and be practicing. So, Sarah, I know you have some updates for us too.
I do. I wanted to note also, if folks wanted to really dig into SIPAC, that interstate compact for interjurisdictional licensure, several episodes ago, Margot and I really dug into that, and we go deep on it, and I hope it's helpful to folks. I'm being self-referential, I suppose. Another new announcement that I think is pretty exciting and interesting for psychology is that of the Drug Enforcement Agency, or the DEA. The federal agency that oversees drug enforcement, announced proposed permanent rules for the prescription of controlled medicine via telemedicine. And this is an expansion that occurred during the public health emergency, or the PHE, excuse me, we're acronym heavy today, wherein they sought to extend those critical therapies to people, such as medication-assisted therapies, or if they need buprenorphine for the treatment of opioid disorder. The changes that happened during the pandemic sought to make that more accessible. So the new proposed rules are in the spirit of continuing that expansion. And I should mention that these rules were made in pretty close collaboration with U.S. Department of Health and Human Services and with the U.S. Department of Veterans Affairs. And basically, it's a proposed extension of those flexibilities that were adopted during the pandemic. And this actually refers to a pretty narrow subsection of medications, but it's pretty darn relevant. So basically, this refers to those telemedicine consultations by a medical practitioner that have never conducted an in-person evaluation of the patient and that result in the prescription of a controlled medication. So the new rules that are proposed, and I want to be really clear, these are proposed, they have not been finalized. Everything suggests they will be, but proof's in the pudding. The new rules would be that prescribers are allowed to prescribe a 30-day supply of Schedule 3 or 4 medication, non-narcotic controlled medications. Additionally, they are allowed to prescribe a 30-day supply of buprenorphine for the treatment of opioid use disorder. And this is without an in-person evaluation or referral from the medical practitioner, 30-day supply only, as long as you are complying with all the other laws and doing as you should. And again, this is narrow. This does not affect the prescription of non-controlled medication, which are generally permissible over telemedicine. And this does not impact when there has been an in-person medical evaluation, which again, generally is permitted. So why are we talking about this? Why is this important? Well, of course, many psychologists in their jurisdiction may have prescription privileges, so it is relevant to their practice. And it is the expectation that this will become law. Of course, that needs to be finalized. They just closed their period of public comment. But I think this is pretty meaningful for all of us, even if we don't prescribe. I think it is a compelling movement in how things are going post PHE. We're going to talk a lot about that today. And I think it's going to mean a lot for how we can work with our colleagues who are prescribing. We're all aware that there is an opiate crisis in this country and that there is a dearth of appropriate providers to prescribe these medications. So our ability to refer, to consult, and collaborate in multidisciplinary teams with prescribers, if we ourselves do not have that privilege, I think is expanded, and it is toward the good of patient care. So I think it's really exciting. We'll hopefully see what happens next, but it's looking like that's what's going to happen.
Fantastic. There's just so many changes coming down the pike this year. And, we had that occur a few years ago where we all had to pivot, but now we've got some innovation, I think, that has sprouted up from our time with the public health emergency. And we're now moving into how can this roll into some good things for patient care and provider, I would say, self-care in terms of just feeling good about the work that we're doing and having balance with that and being able to connect and collaborate more. Well, should we get into our topics today, Sarah?
Certainly.
All right. We always select a couple things to really provide some deeper detail on, and that comes out of some of the conversations that we've had or in our review of questions, the heavy areas that the questions seem to focus on. And so one of the areas that we wanted to emphasize today is related to some of the common ethical issues or considerations related to telehealth. And, for a number of folks, really emphasizing that ethical mindset of thinking through and considering how telehealth or telepractice may have morphed into something a bit different than what our usual practice was when we were seeing patients within the office setting. And so a couple things that have really risen to the top here in terms of challenges or concerns relate to security and privacy of the patient-clinician relationship. And we see this in a few different ways in a few different areas that really are quite different from the in-office experience, meaning within our office, we've been used to kind of the walls containing the session. And once we move to the telepractice medium, we really have different kinds of walls there and things that we have to pay much different attention to in terms of security and privacy. Some of this comes from the tools that we're using early on in the pandemic time. FaceTime was acceptable. It's no longer acceptable, and it's for sure not going to be acceptable as things continue forward. And so we need to be very cognizant of what those HIPAA compliant connections are, and how patients are accessing our sessions online, and being very aware of the tools that we're using for that. We've talked throughout most of our chats in terms of video conferencing platforms that are acceptable, and certainly there's more coming to bear in that environment. But we really want to be cognizant of the security and privacy factors that are involved with having a HIPAA compliant platform. Another thing we want to think about is just issues of security and privacy surrounding documentation, and not just the communications aspect of those documents, but also the signatures or passing back and forth of how we're actually getting information from our patients in the old paperwork forms. And so some of those platforms are really handy for streamlining all of those electronic medical records into one place and containing that in a compliant platform for you. We've had a number of questions about, well, mailboxes, post boxes, what if I'm not in the office anymore? How do I manage this? All of those same considerations that we have with paper and keeping them locked up and not in our home, but at the office or in our home office, contained in the same secure manners that we had, in the office setting, is still important. And the same is true with those digital files. I think the other aspect of this is also thinking about the locations that patients are connecting with us through. So, I think we've had questions come in about what if they're in their home and there's other people present? What if they're in their car? What if they're driving? What if they're on the road? The security and privacy of that patient-clinician relationship is so key for the work that we do, and making sure that patients have an understanding of the importance of those boundaries, and just the ease of access that telepractice allows for us sometimes has cropped up to get in the way of those structures for that boundary of that confidential relationship. And it really is the onus of the provider to help patients understand that even though it's easy to access care this way, we do have to be diligent and make sure that we're still honoring the essence, honoring the importance of patient confidential interactions and conversations. So when we're building our relationships with patients, what used to happen in the office as this closed, secure, boundary kind of walled relationship, we have to really work at creating some of that in terms of honoring those same things, but also letting patients know how this works. And it may be very different to how things go from a healthcare provider standpoint that they may have been used to. We still have to teach that within our relationship with our patients. So we thought it just helpful to dig in a bit and talk through some of the themes that we're seeing in the questions that, even though it's easier perhaps to access care through telehealth means, it doesn't mean that the outcomes are going to be exactly the same, because we may have some changes in those boundaries and the structure in the seriousness or the diligence for which patients are experiencing the care that may change that slightly. And so we want to be sure that we're working with our patients to really understand what the session means, what the importance of setting appropriate time boundaries around it, appropriate access. Don't check in from your desk at work with your colleagues in the background. That's not going to provide the most comfortable way of providing care. And we should not be, if we know this with our patients, should not be continuing our sessions in that realm as well. So just a few things to think about.
That's well said. And I think, this is the theme of the day. right? Like thinking about those ethical issues as we move forward. And, we all made this massive transition 3 years ago. And here again, I think we're being asked to, not in quite the same scale, but ask ourselves, what's next? I see so many good questions, and some of them I'm very excited, I know will be answered on some of the themes coming up next, but if we may, shall we go to a couple of them, Margot?
Absolutely. Let's jump right in. I love it.
I just really like the way they said it. What is the outlook of insurance coverage for telehealth once the PHE is lifted? And the reason I'm so excited is I can say the outlook is good. Like the magic 8 ball you shake. It is very good. And we're going to talk a little bit in a moment about the specifics of Medicare. And the reason I'm mentioning Medicare is, of course, it is the largest insurance provider in our country, but it is also, as Medicare goes, so often private insurance goes. And what we see is that during the pandemic, Medicare expanded coverage to include audio visits and video visits in the home. Now, they previously had permitted video visits in the home, was a question of great debate. You still have to meet all your other Medicare eligibility criteria, but we're going to see post-pandemic, those changes are permanent. Now, you could just say, well, gosh, that's just Medicare, and that would be a reasonable thing to say. But again, as Medicare goes, we see that tends to be how private insurance goes as well. So I think it's really exciting, and I think it's a really positive trend line. Of course, you always have to check with the individual insurer as to how they will treat these things. But to my best of knowledge, that really is the direction things are going. Patients liked it, outcomes have maintained, and we're going to see a lot of continuation of coverage.
I think you raise a really key point there, and that is, as these things change in the next month or so, it's going to be very key to continue to have communication with the coverage, the insurance providers, to know what is coming, if they are going to be following that for your ongoing patient care, and encouraging patients to do the same, because those may change. They may revert back, and nobody wants surprises with that. And so, always helping patients advocate for, how they can find their information as well, I think is really important. So I appreciate you identifying that for us too.
Absolutely. I saw another one. There's a lot of SIPAC in here, which is great. I think, unfortunately, we won't get to all of them, but there are a couple in here. Please know I will be researching in between now and then. Specifically, how do we make sure that folks who may be graduated prior to electronic records are getting their work recognized and can participate? So know that I will do my homework. But here I see one that says, people here in Oregon are concerned about joining SIPAC for fear that people from out of state will be taking their patients and reducing reimbursement. Any thoughts? Any ethical or practical implications for a state without this designation? And I mean, you bring up a really good point, which is, well, hold on, if we were to join as a state, does that not open the marketplace to providers outside the state? I think that is fair and a true thing, that, if you are a participant in SIPAC, that means that people from out of state could come in and provide service to residents. I will say, I have not heard about this reducing necessarily reimbursement, although I have heard there's this general concern that, let's say someone who lives in a place that's just much less expensive, could offer services at a much reduced cost. I will say I have read about insurance companies starting to think a little bit about, the reimbursement rates, about keeping that consistent, that they want to make sure that care that happens in California is reimbursed at California rates, for example. But I appreciate the meta point, which is, if we open ourselves in this way, are we not opening ourselves to coming in and taking clients? I mean, I think it is a true thing. I will also say that, and I can't speak for every state, in many states, there is such a dearth of providers. There are so many more patients seeking care than providers available to deliver the care, that, and I can't speak to any individual market. Someone might say, well, gosh, maybe, but for my specialty, that's not the case, which would be a totally fair perspective. I think it's valid. I would say that I have not heard anecdotally nor read anything about that meaningfully impacting provider communities negatively. I'm going to be transparent. The thing I'm much more worried about is AI robots than people coming from out of state. But that's just my own anxiety and not something I need to give to you. But I think it's a valid point that when people do participate, they are opening that marketplace. I'd like to point out that you're also expanding your marketplace as well, that you can then practice into other states as well. And I will share with you, as someone who has a SIPAC license, I have never had the experience of losing, quote unquote, a client, who is going to come to me and say, well, gosh, so-and-so over in Kansas is going to do it cheaper. I have had the experience of following a client, or they're moving to a SIPAC state and I can continue care, or I have had the experience of being able to take a referral that I wouldn't have been able to take otherwise. That's anecdotal, but I think, Margo, what else might you add?
I think you really covered the perspective here that we're living in a mental health crisis. And that doesn't necessarily extend to all markets and all providers, but there is more than enough work to go around. I think it opens the door for patients to perhaps find connections with providers to do meaningful work that they may not have otherwise. But it also, like you mentioned, allows providers to connect with folks in other places to do meaningful work that they might not have otherwise been able to do as well. So I think, all the way around, maybe it's not a needed thing in a particular jurisdiction, but it's something that we see across the board in many kind of disciplines, that the more opportunities there are, the more people reduce their excuses to seek care and are able to find somebody to work with.
That's a good point. All right, I'm looking at the time and I know we have much to get to. So these are excellent questions. In interest of time, shall we dive into our next topic from last time?
Absolutely. Absolutely.
Right. Last time we had a question, which was such a good one. And I was very tempted to answer it in real time. And it was, is the PHE, the public health emergency, different from state to state? And I saw the question initially, I was like, oh, easy. No, it's a federal designation. And then I thought about it, I was like, wait, that's actually hard to answer. And I should wait till next time when I have a more comprehensive answer. So that's what Margo and I kind of picked and what we're going to talk about today. So, what are we talking about here? The Department of Health and Human Services has decided that the public health emergency, the PHE, for COVID-19 will expire at the end of the day on May 11th, 2023. And for those of us counting along, this was first declared January 31st in 2020. So that's about 3 years and some change afterward. This was a federal designation, so its declaration and its end is the same for everyone. But I think it's worthy to pause and think about what this means from a national level, what this means within your individual jurisdiction, and then what it means in your office, because I think those could be 3 distinct things. And so we're going to review a little bit some changes that are coming again at the federal level, and then how to think about state and your office. I do want to mention though, I hope this isn't stressful at all, because here's another thing we should know. The Consolidated Appropriations Act of 2022 was basically a federal act that allows 151 days of transition time after the public health emergency ends. So yes, there will be some federal policy changes coming down the pike, but the general regulatory attitude that we see in this act and in other places as well is one of understanding that this is a transition, which doesn't mean we aren't accountable to make it and shouldn't do it as quickly as we can. But I will say that that act and other places, we do see a general ethos of understanding, there's been some back and forth. So what are some things that are likely to change? Margo made reference to this too, but it bears repeating. During COVID, practitioners were permitted to use non-public facing, non-HIPAA compliant communication tools. So that was like Skype, not Skype for Business, which is HIPAA compliant, funny thing. That was like FaceTime. That was like just using Gmail, email. And there was just a general regulatory attitude of hey, Department of Health and Human Services was saying, we're not in the business of trying to, go after practitioners who are just trying to see their patients during a pandemic. We want to support them. Now, we don't want them to go on Facebook Live. We don't want them to have a live webinar with their client session. We want them to use private tools, but we're going to be a little more permissive in what tools they can use. That is something that is going away with the end of PHE. Now, Margo, I know you and I have always been on the side of let's try to use tools designed for healthcare, something that will offer you a document called a Business Associates Agreement, or BAA, that says, hey, we recognize you're a HIPAA compliant entity. We're going to follow the rules too, so you don't have to worry. So it's still true today. So if you have been using a product that is more informal, that isn't complying with HIPAA, it's time to make that investment and to transition either back or over to a product that is. And the good news is there are lots of products on the marketplace. I'll mention a few, though there's not like one that I think is the one. There's Zoom for healthcare. There is integrated video conferencing in the Simple Practice tool, if you use that for your practice management software. There is Doxy.me, which has the lovely benefit of being free. There's VidYO. There's tons of products marketed specifically for healthcare providers. So there's lots of good choices. So that's one change. That leniency is going away. The other thing, Medicare in-person requirements. Prior to pandemic, Medicare said, hey, if you're going to see somebody virtually, you need to see them at some point within 6 months of first seeing them in person. That was suspended during the pandemic. Now, what Medicare has said is it's coming back, but it's coming back January 2025, so you have a little bit of time. And I will say the blogs and whatnot say, gosh, January 2025 is a long time away. We'll see what happens. But meanwhile, we should all plan for that coming back, that if we do see Medicare patients, we should start getting back in the practice of having an in-person assessment with them within 6 months of that first meeting. So those are the things that are likely to change. A couple things that I'm happy to report are going to stay the same. Medicare, as we said, the reimbursements for audio and video, still going to happen. That is a permanent change. We talked earlier about controlled substances and the expansion of prescription for controlled substances without that in-person assessment, that permission of the 30-day supply of certain medications. And it is expected, as we talked about earlier, that that's going to stay the same. So these are the federal things. So let's talk about your state, because although, yes, the PHE is the same for everyone, how our individual states and jurisdictions interacted with that was actually pretty different and divergent. Many states had different types of mask mandates that they implemented at different times for different lengths. I know in my home state of Washington, the requirement of indoor masking in some medical environments is going away pretty imminently. And it's, kind of throwing folks into this question of like, oh, well, gosh, what do I do in my practice? So I really want to encourage, even though there is this federal mandate, it is really valuable to know what your state, your jurisdiction is requiring. Typically, this is found on your Department of Health website. It can also be found on your Department of Psychology website. Often they'll link to it. So what's relevant in terms of masking, what's relevant in terms of notification, and some of these other COVID-specific themes. Again, as Medicare goes, private insurance tends to go, but if there is an insurance that you partner with primarily, it's a good idea to check in and say, you're going to keep on reimbursing that, right? Many states passed legislation that required that the telehealth appointments be reimbursed. Some was legislation that was permanent, put into law. Some were these kind of emergency mandates. So it's worthy of contacting insurance you work with frequently and checking your Department of Health website. So, we've talked about what's going to happen federally. We've talked about what's going to happen at state, but, what's going to happen in your office? And I really, I really believe that we have to practice in ways we feel good about, in ways that we feel safe, and ways that feel right for you. And we are not required to practice in ways, that we don't wish to. I should say, within the constraints of the law. So for example, folks have asked me, well, hey, I actually like the masking, and perhaps they're immunocompromised or someone they love is, or perhaps they just really like not being sick, and they're trying to figure out what to do with this. And I always like to remind folks that you are allowed to mask. You're allowed to ask people to mask. If you have clients who don't wish to mask, you have to offer an alternative. And in many instances, that's telehealth. And so, you can have policies for your office, for your practice that work for you. You have to communicate it in informed consent. And I hope we'll have thoughtful, flexible conversations with our clients, but provided that we're offering alternative ways to see folks, this is something we can do. Maybe we want to think a little bit about our office space. Many of us may have invested in snazzy dried flowers for our at-home office. We maybe gave up a professional office space. As PHE transitions, does that still work, or is that something you want to revisit? So to our patients, I had a lot of patients working from home offices who could sneak in a midday meeting, and that was great. Now they're in their office, perhaps in an open office plan, and they still want to have that meeting. That doesn't work as well for privacy and confidentiality. So as our patients are making these transitions, we can think a little bit there as well. So in the context of all these changes, I think these are themes we've talked about before, but there's just this opportunity to pause, think about, what we know the changes are coming down at a national level, investigate what's happening in our jurisdiction, and then kind of check in with ourselves as to what works for our practice and the relationship we want to be in for our clients.
Sarah, there's so much goodness in that in terms of just things to think through. And what we've consistently talked about over time, even when we were doing the workshops previously, is thinking through this ahead of having to implement anything is so helpful. It gives you space to figure out what your office policies are, how you are comfortable, or even your staff is comfortable with that. It also helps you have those ahead of time conversations with clients, even in paperwork, in terms of what's in your consent. So taking time to think about these things. And as you mentioned, the PHE will end, but there is a grace period, so to speak, in terms of the getting adjusted and revising things post time frame. And so, thinking about it now is not too early. I'll just say it that way, I guess. I know one of the things that I've been thinking a bit about, and maybe is something to dig in a little bit more on a future topic, but is cybersecurity insurance. And as we are going through a variety of different kind of transitions at this point, with a lot of these changes coming, we really should be all learning more about this. So I'll tag that for maybe a future topic for one of our chats, but also just to plant that seed for folks out there that this is something you're going to want to be looking at and investigating and finding out more about, and how it's relevant to your particular practice, your particular situation.
Especially, if you, like so many others, are going to maintain an online practice, either full, I actually have an exclusively online practice at this moment and probably going to stay that way for a while. But some folks are having hybrid practices. It's a worthy investigation. I saw some more good questions. Should we hop to some of those, Margot?
Yes, absolutely.
I like this one. I like them all. I have read that audio video must be HIPAA compliant, but VoIP does not meet this requirement. Many large offices, mine included, uses VoIP. And for those folks who don't know the acronym, VoIP refers to Voice over Internet Protocol. If you've ever used Skype Voice, or if you've ever used Google Voice, as a telephony mechanism, it uses this protocol where it actually sends the data over the internet to have your phone call. It's a great question, and this is, I hope this is an answer, not a non-answer. What is really confusing to me, and to many, I think, is we actually talk, and I will opine again and again, that we should use products that, video conferencing products, audio products, that align with HIPAA, that comply with HIPAA. What is really interesting is that HIPAA was written before, the advent of, a lot of video conferencing softwares and things like this. So you actually will not find in HIPAA specific mention of video conferencing, and actually a pretty permissive treatment of audio. So it's like, and then a lot of these companies will try to say, well, does it matter that we comply with HIPAA because, it doesn't even require us to comply, which is fair. But I think as much as we can, we want to use compliant products. VoIP is a really great example, though. It is legion. It is everywhere. And I think if you work in an office where you have an enterprise solution that uses VoIP, there's a good chance there are securities in place that will be thoughtful about privacy and information security. I do think if, as an individual independent practitioner, if you were making that choice, like, well, do I use Google Voice for my practice or do I use something else? I will say there are HIPAA compliant VoIP options. They're marketed to healthcare people. You can just go down to T-Mobile and get a second phone to get a landline. We can get all kinds of things. Landlines these days are VoIP. So, there's no, I think most of us are using VoIP, whether we realize or not. So I would say enterprise level solutions often do have security that is generally pretty satisfactory. I am not aware of any circumstances about folks getting in trouble for using an enterprise level VoIP. I would say as an individual, given the choice, I would again choose something designed for healthcare, or consider just getting a second line on my phone or something like that. But that's not, in terms of risk management, it's not a risk I would be overly concerned about. Just I think there's very little precedent. And I think those large companies do tend to do, maybe not to HIPAA exaction, but then again, HIPAA has a very lenient treatment of phone calls. Excuse me, the technology of phone calls.
I think it also depends on kind of how you're using it and who your patient population is. There's going to be some circumstances where that is, you need a higher bar, so to speak, or you do want the landline. And so I think, like you're mentioning, Sarah, it's worth digging in a little bit, because you may be surprised that there are some security features in place for the system that your office may have, or that you didn't even know you needed to look into this, which is, again, why a cybersecurity insurance policy might be something you want to also learn more about.
Yeah.
So
We are, we're psychologists, not technologists. And I think there are these moments where it's like, well, goodness, we do our best. We do our best. We document that we did our best efforts. We try to use products that align with our aims. We do.
Well, and that's a really good point, Sarah, that there is a really good reason to reach out to a technologist, to a person who understands the technology that you might have in your office, to do an audit or to ask the questions of, so that you can know exactly what you're using and leverage that, as opposed to try and figure it all out yourself.
So there was another great question, which is, what about psych consultation services, such as a neuropsychological evaluation, where there is one or maybe two appointments, your assessment, and then your initial, the assessment, and then the feedback. And sometimes those appointments might range 6 to 12 months. And I think they're specifically referring to needing to see someone within 6 months. Again, I want to mention this refers to Medicare. We'll see what happens post-pandemic with private insurance, because as Medicare goes, often so private insurance goes. That one I will be interested to know, because it's a very unpopular one, but we'll see. The thing I would say is that it is not uncommon for folks to have like a meeting that explicitly satisfies this requirement. For this reason. So a lot of times it will be a more brief meeting. I have colleagues who tell me they're like, I just schedule that meeting quite briefly because the work is going to be done over telehealth, but this meeting will accomplish some, paperwork or something, pretty rudimentary. It fulfills the brief, it meets the need, and I think sometimes Medicare is quite prescriptive about what meetings you can and can't have. So I would encourage folks to be thoughtful about integrating it into a meeting where it just makes sense. If it just doesn't make sense to do it at the feedback meeting, trying to do it earlier, trying to anticipate the need. Not a terribly satisfactory answer, but it does still hold for evaluations. So I think that is the question. Yes, it applies. Colleagues, of mine who do that work suggest that they try to fit that in a way that doesn't interrupt the flow that you're describing. That timing is so important.
Related to that, Sarah, we also have questions that come in routinely about, interjurisdictional telepractice to another state. And I would refer folks back now, as the pandemic, the public health emergency rules are ending, that they really do need to check back into what has transpired in their jurisdictional laws. Because prior to the pandemic, some of those requirements for telehealth were to see people in person, and then you could go on and see them. If you created or started that patient provider relationship in person, then you could go on and do telecare. Now, those may have changed in the past 3 years. They may be on the books to change, but that may still be something that your jurisdiction is reverting back to. So you're going to want to check into that as well, not just the Medicare guideline changes.
Just one more question I want to sneak in, because it's a quick one. I think we can do it. Are typical cell phone plans risky? And again, I have a brief answer. No. Generally speaking, again, HIPAA is pretty permissive in terms of like what telephones we can use. I will say there are telephone services that are specifically geared towards medical providers. And if that gives you a feeling of confidence and security, absolutely. The biggest risk to cell phones is how you use them. I am so much more concerned about me standing outside and talking really loud into my cell phone where I could be overheard, or taking a call in an inappropriate place because, gosh, I've been waiting to hear from that client. Those are the types of things that I think are greater threats to privacy and confidentiality when it comes to mobile device use than using T-Mobile or AT&T. So no, I don't think it's terribly risky. If you wanted to be ironclad, you can use one of the services that are oriented towards healthcare. I'm going to put in the there, I see some comments in there like, is there a place that reviews things like this? There is. It's called Capterra, CAPTERRA.com, and they do reviews of technology products with an eye towards healthcare. I'll put that in the chat in a moment.
Sarah, you do raise an interesting question, because we're thinking about this from a provider standpoint, right? But it's also important to think about it from the patient standpoint in terms of where are they standing for that phone call? Where are they and who is present? And I saw an earlier question that came through about, well, if the patient's okay with their Aunt Susie being in the room, then shouldn't we? And I really, you know, we've talked about this previously, but I think it's really important to address. This is all part of kind of that teaching of what creates this important space of work to be done, whether it's on a phone call, whether it's on a Zoom or a video. If you're not bringing those folks into an office setting where we would do paperwork for release of information and make sure what the reason is that person is present, we probably don't want to do it for the telephone call or the video conference session either. And so it doesn't matter what the patient is being permissive of. It matters how we, as the providers who are licensed and knowledgeable and informing the patient of how this relationship goes, it matters what we do in that circumstance. And I would say no, unless that person is part of the therapy session and we've got a release, they should not be there.
I would like to compliment you on your seamless transition, because this was the question we received last time, right? I mean, in part, it was, you know, I think we had someone write in, and I found this so relatable because I've had this happen too. We have a patient, the patient is in an open office setting, and they're telling me they're unconcerned about privacy. They want to have this meeting anyway. No, the Wi-Fi, yes, the Wi-Fi, you know, is administered through their work. Yes, the work has a policy where they can take snippets of, you know, whatever you're doing on your screen and look, you know, yes, people could overhear me, but I have informed consent and I don't mind. And what do we do with that? I think it was like, I actually looked back the other day, one of the first webinars we ever did talked about this issue of when people tell us that they're not worried about privacy and confidentiality, you know, what do we do with that? Because I think we have to respect patient autonomy, and we have to appreciate the ethos of, you know, they get to make decisions for themselves, of course. But I think there's a nuance here. So it's like the bottom line is, to me, bottom line is we are responsible as professionals to maintain privacy and confidentiality. We are beholden to HIPAA privacy, HIPAA confidentiality. We are beholden to high tech, which is a data security law at a federal level. And so that to me is the bottom line, but there's nuance. You know, this isn't solely between my patient and myself. This is between myself and my licensure board. So my patient may want to speak to me about having flexibility and treating these rules differently. And I think it's a valuable conversation to have, and I want to listen and learn what their concerns are. But I think patients have a discretion that we do not necessarily, because they may grant me that discretion and I appreciate it. That doesn't mean my licensure board is going to turn around and say, oh, well, don't worry about it. Now, if it was absolutely necessary and I could provide my patient care no other way, you know, then I would have to look into it, document the heck out of it, consult you, Margot, 1,000 times and write that I did that, talk to my risk manager at the trust. I would do all the things, you know, but I think that's the minority of situations. I think we are living in this time where these mores are changing. People's attitudes towards privacy and confidence are changing, but yet we have to be these standard bearers because we are professionally required to do so. I think there was this nice metaphor for clients, you know, it's like you may decide to put the results of your latest physical on TikTok, but you probably would not like your primary care doctor putting the results of, you know, your latest results on TikTok. So I think there's this notion of like having these difficult conversations and, you know, we are in these like beautiful, authentic relationships with folks, but reminding them that we are beholden to an infrastructure that is there to keep them safe. And that, you know, maybe it's kicking the can down the road, I don't know, but like it or not, those are the rules we are governed by.
Right. And I think too, you know, as we kind of started out in terms of this idea of the security and privacy and the ethics of that that's kind of the foundation of our working relationship. And the distinction and difference between, getting advice from your Aunt Susie that, she doesn't have all those things she's beholden to, even if she has the training. But, it's that setting this up as a really important working relationship that's different from the other maybe less formal relationships that you may have in your day-to-day existence. And it is incumbent upon us as the professional to be the one who holds that as the standard.
Speaking of professionals and what standards apply, I saw a question in here that I think is a good one too. What is different if you are providing coaching rather than psychotherapy healthcare? And that's a really good question. And I want to encourage folks to, and I will try to put this in the chat, to go to the Trust website. Eric Harris, just a brilliant attorney who's had a long history working with the Trust, wrote a piece on this for the Trust. It's on their website that really beautifully articulates some of these concerns. And I think I'm going to give a deeply unsatisfying answer, which is, well, it depends. What's been really interesting, and I just learned this recently, are the different treatments of the activity of coaching state to state. For example, I learned that in the state of Colorado, the Board of Psychology has opined that coaching is a psychological service and requires licensure and is governed by the rules of licensure. I didn't know that. I thought that was very interesting. So I think that what is really valuable is to understand the rules of your jurisdiction, as in any case, to have a really thoughtful, thorough trail of documentation, a really thoughtful, thorough trail of informed consent. Personally, I would err on the side of wanting my coaching work to be private and confidential for various reasons. I mean, honestly, but I think one could make the argument that there was the lesser risk, but personally, I would want to understand really well where I was doing it, how they treat coaching. I'd want to document the heck out of it in my informed consent documentation, and whenever possible, try to make things confidential and private, because I think, I don't know, I'm a believer that that's going to be a really good environment to create rapport and to create other good things in that relationship. But I would certainly, I appreciate the ethos of, coaching has a separate set of rules in some jurisdictions that don't treat it the same.
I think it's really, really important to understand that it's more than Colorado. There's several other jurisdictions that include life coaching, other terminology that would indicate coaching as part of a licensed practice. And so I think it's no longer the case that you can just say, well, I was doing coaching and kind of treat that differently. You really do need to evaluate what the scope of practices are in those laws. And like Sarah said, I really think, having those same contractual, documented kind of rules about what is that relationship and what's entailed and what is confidential, that all should apply no matter what that working relationship is, because coming as a professional, that's part of that kind of structuring of the relationship.
Right. Well, do we have time? One more? Should we do a quick one?
I think we do. We've covered a lot, but there's so many really awesome questions. So let's try to do one more.
Sorry, I have to admit.
I see one that is jumping out for me at the moment.
Please.
What if a client wants to record the session? Is that allowable? And I think this is really good from a few different standpoints. There are some treatment protocols that actually do record the session. And so we want to be thoughtful about what are the reasons for recording the session, what's the purpose that we're going to be recording for, but also having those conversations with the client about, is this therapeutic or is it to, post up on TikTok, in which case, we want to make sure our documentation is describing well what the purpose of this is and what the use is and how we would want to maintain that. And so, Sarah, I know you'll have some other contemplations on this one, so I'll turn it over to you.
I'm very much aligned with what you said, and as always, if you did determine that this was therapeutically aligned, make sure that you document. I even encourage folks to have a separate informed consent related to recording and just document it. Make sure everybody understands the risks and the benefits, because anytime you're storing information, there's a risk to information. So, but it's a great question.